Our speaker today is Dr. James Backstrom. He is the current Chief Medical Officer for Foundation Radiology Group and an OHA corporate partner. Dr. Backstrom holds a Bachelor of Science degree in biology from Westminster College and his medical degree from the University of Pittsburgh. He completed his internal medicine internship at the Bethesda Naval Hospital and the Health Quantico Naval Clinic. He also completed a diagnostic radiology residency and a 6-month fellowship in neuroradiology at Duke University. For his pediatric training, Dr. Backstrom completed a pediatric radiology fellowship at the Children's Hospital of New York and also completed a 6-month pediatric neuroradiology fellowship at the Hospital for Sick Children in Toronto, Ontario, Canada. I'd like to please welcome Dr. Backstrom.
Thank you, sir. Appreciate you inviting me back. For those of you who are with us for Alara 2.0, this is an update and a version that will allow us to further explore some of the Alara things that have happened since then. I am going to spend the first few minutes of this talk going through some of the salient points of Alara 1.0. The Hospital Association has that full lecture on file. We'll go through some of the salient points around there before we get into the meat of Alara 2.0. So let's just get started because we have a lot of ground to cover. I appreciate everyone turning up. Obviously, Alara is as low as reasonably achievable. We want to make sure that radiation exposure to our whole population and to our patients is as low as we can possibly get it. And this lecture is an attempt to help in that endeavor. Long ago, I used to play guitar, and I used to play a lot of this guy's music, but he doesn't look anything like Cat Stevens anymore, and clearly has changed his philosophies in life probably a little bit as well. And although we don't like to go back to the way things used to be, we're all sort of entering a new age, and that new age mandates that we really act and do things in a very different way with respect to our patients. And for radiology, a cataclysmic event occurred back in early 2000 when this report came out by Brenner, Elliston, and Hall, and basically raised the concern that perhaps even small doses of radiation that we might see in pediatric patients could cause some radiation problems. And it caused a statement to be made that said the best available risk estimates suggest that pediatric CT will result in significantly increased lifetime radiation risk over adult CT, and went on to basically say that you need to consider very closely when we're giving CT to our patients and to be sure that the risk-benefit analysis is really tilted in favor of the benefit. And that's essentially all that it said. It was a very good message. But what happened is that the press picked up on that, and this in January 22nd of 2001, created basically this. It created sort of a nuclear explosion in the pediatric world and in the population at large, causing radiation to be seen as quite evil and poisonous. And for us, as radiologists and people that are taking care of patients, created an awful lot of questions that had to be answered. But it's not that this is new information for us. Since way back when, in fact, when radiology was invented by Rankin, we've known quickly that radiation produced some significant problems, and we've been reminded of that multiple times throughout history, including Chernobyl and Marie Curie and the atomic bomb mishaps, as well as Hiroshima. So we know radiation has clearly some effects. But back in 2001, the pediatric radiology community did a series of articles that have extended up through 2011 that have basically allowed us to really dive into this much, much deeper. Just for the purposes of our discussion, you need to know at least some of these terms, knowing that sieverts and REMS are really terms of radiation protection and absorbed dose equivalents. Gray and rad are units of absorbed dose. You're going to see a move towards BERT, which is essentially comparing radiation exposure to background equivalents. And I'll just put this slide out there because this will become useful and to remember as we go forward. But what essentially happened in this article is that in the old days, this is how we looked at atom bomb survivors. We didn't really know what happened in the dosages of conventional radiology, and there was a lot of concern of whether we should be extrapolating in a linear fashion from that data, or should we be extrapolating in a superlinear, or just that there was actually a threshold where damage occurred. And essentially what came to pass with that article is that we were able to prove through population evaluations that the dose range for pediatric CT did produce some measurable increase in a risk for later events that are radiation induced. And this lifetime risk for a single small dose of radiation is really what produced that article. And we know that females were more prone to effects than males. Again, the risk is very, very small, but it was a measurable risk. And if you put that in the setting of doing more and more films and knowing that some of the newer modalities produce much, much larger radiation exposure than, let's say, the old chest X-ray or the skull X-ray or the C-spine X-ray, this created then quite a problem. Additionally, even in children, you can see that the amount of radiation and the amount of CTs that were being performed in this population is increasing significantly over time, just as we know that the risk exists for both abdomen and pelvis as well as head CT scans. And note on this graph that the abdomen CT scans actually overall have a greater risk than the head CT scans. And so how do we get into this whole conundrum? Basically, in 1980, 3 million CT scans were performed in the United States. I'm sorry, 3 million, and in 2005, 68 million scans were performed in CT scans in the United States, and that number has actually gone up until very recently, where things have actually leveled off, particularly in the pediatric population, and it seems to be leveling off in the adult population, almost certainly a result of both economic issues and Alara issues. But why did CT scan utilization go up? Well, patients and parents demand that they know the answer to something. CT is very effective in providing answers. Litigation concerns and the lack of tort reform has helped with this process. There's a demand for immediate care and triage. We go to places where people put the number of minutes of waiting time in the ER. So there's a lot of concern about getting the answer, getting it quickly. CT scan, very effective in doing that. It's essentially a convenient way to get an answer in a lot of radiology problems. But one of the questions we ask ourselves, do we really need that much radiation to answer the question? If you look in 1974, the scan in the top left was done to look for hydrocephalus. I can tell you that there's no hydrocephalus in that examination. If you look at the 1980 scan, the pictures are much better, but for the purposes of looking for hydrocephalus, it doesn't provide us with much more information. And clearly, we need to be asking ourselves, can we get perhaps pictures that are not as pristine, but do it at lower radiation doses? And that's exactly what Alara in the CT world has been asking over the last 10 years. So what we're in search of is basically radiation Goldilocks. We're looking for those radiation exposures that sit just right with the patient. And there's a number of things that we discussed in the last lecture that we can actually manipulate and hopefully manipulate in a way that's positive for radiation exposure. And I'm going to go through those very, very, very quickly. Pitch. We know that if we throw the patient through the scan at a faster pace, they'll be exposed to less radiation. Often machines are defaulted to a pitch of 1. You can often get very good pictures and adequately diagnosed pictures at pitches of 2, which decreases the radiation exposure significantly. Length of coverage. Don't just do an abdomen pelvis because it's ordered. If you only need the information that's contained in the pelvis or you only need the information in the abdomen, don't expose to parts that don't necessarily need to have radiation exposed to them. And this obviously means that you have to have conversations with your physicians. It's also obvious that we probably should do as few non-contrasted and contrasted scans in tandem. And you can see the government agencies also have a focus on this particular point as well. We know that there's been a great effort towards decreasing the MAS and decreasing the dose, and you can see that decreasing the MAS combined with basically increasing the pitch really can result in very, very low doses, and there's a lot of protocols now being advanced, and I'm sure you're all using many of these, that allow for smaller doses to be performed and allow for still diagnostic images to be obtained for our patients' benefit. In addition to these, we also discussed some of the other things like bow tie filters and positioning. Again, we'll go through these very, very quickly. But for instance, bow tie filters and newer CT scans have really resulted in a lower radiation dose. This diminishes the soft radiation that's absorbed. It's not useful for imaging that aren't useful for imaging production. These have their effect prior to the radiation reaching the patient, and they concentrate radiation essentially appropriately to the thickest part of the patient, and often can reduce the surface dose by as much as 50%. They need to be utilized, turned on, and understood. Additionally, just paying attention to something as simple as putting the patient in the center of the scanner is very, very important. This decreases artifact and it actually enhances the functionality of the bow tie filter. It also allows the automatic exposure control to work more efficiently and thus decreases the dose. In addition to this, we also have to be very careful that we tailor the exact imaging specifications to what we're trying to find. Looking for pulmonary nodules, some skeletal imaging, and lung imaging really allows us to use very, very low doses of MA and still get an adequate answer to the question. And again, Conversations with the physicians, education of the physicians allows us to lower the radiation dose and allows it so that one size clearly doesn't fit all in a well-designed Alara department. And this is something I think is often forgotten, but friendly environments are important. Having a patient hold still is important to make sure that we don't have to repeat scans and to allow for fast scans. Upfront personal interaction can be a real time saver here, and it can be a dose saver. Providing care is a very important part of what a technologist should do in addition to just pushing the button. And entering all info into the scanner prior to the patient being put into the machine is important and clearly decreases the anxiety around putting people into these relatively scary looking donuts, as you can see on the slide. Single phase imaging, again, not doing non-contrast and contrast exams as a matter of course unless there's a pure clinical reason for doing it, so single phase imaging clearly is the dosiest number. So just as a summary for CT, it remains a major diagnostic tool, it remains spectacular in what it's able to provide, but we have to make sure we're doing it with as little risk to the patient as possible, keeping in mind that children are more sensitive than adults, but adults, Alara still is a factor in thinking about their scanning. Children are more sensitive by a factor of 10, and girls are more sensitive than boys. There's an excess cancer incidence in individuals who are exposed to radiation doses that are comparable to doses seen with helical CT. This is really the thing that's gone out to the public, and it really just makes it so that we are very much part of the discussion, and we need to be sure that cost-benefit or radiation-benefit ratios are kept in mind. Trying to put things in terms of BERT and background radiation often helps the patient and the patient population understand radiation more effectively, and we're going to go through a couple of examples of those in a little bit later part of this lecture. Reduce radiation dose but still maintain an acceptable image quality. This is what is important for diagnostic radiology. Only do examinations for appropriate indications, but do them once and do them well once. Use published weight parameters, especially in children. Pay attention to the indication. We've for a long time asked our referring clinicians to give us good clinical data. We are then obligated to use that good clinical data to be sure that we're doing the right exam on the right patient and not producing any excess radiation exposure to that patient. I think all of us have moved away from fixed MA protocols. If you haven't, you need to, and you're going to see a lot more work on this with manufacturers with dose caps and modulating MASs and auto MASs as time goes on. In fact, we're seeing it already. There's also an awful lot of work being done on KV dose reductions that we've experimented with in our group, and we've got to be very proactive in participating in the education of our peers and participating in any and all active discussions when the word radiation is used. We truly must become the radiology consultant. And so this is the study, or the slide that I ended the last examination on. I asked that you would invite me back at some point, and appreciate you having invited me back. And we're going to discuss a few other areas of radiology and some of the things that have happened in the Alara world with those areas. And so we're going to start off with nuclear medicine and PET imaging. I will put a pitch. This will be one of several that I'll give to the Image Gently campaign that's online. They introduced last year a set of nuclear medicine guidelines. I want everyone on this webinar to be aware of them and to utilize them. These are the guidelines. These guidelines are available if you go online. You can get a nice poster of these. But these clearly give some specific recommendations for radiopharmaceutical use that is administered to children and adolescents. It gives an idea of what the minimum administered activity should be and the maximum, and gives you an idea of what you ought to be utilizing in an Alara-focused nuclear medicine department. And as I said, if you're not using these, please acquire them and begin to utilize them. There is an awful lot of work being done in the adult sector, as there is more work being done in the pediatric sector, to make sure this is tailored and honed as well as we can possibly do it, knowing that nuclear medicine is still a significant source of radiation. What I find is that communication is important. Perceptions of risk vary among professionals, and really there's very little knowledge among ordering professionals about the radiation risk of nuclear medicine. So it's imperative then that you do your homework. The media has a natural tendency to stir emotions, and it errs on the sensational side. And obviously for us working in this field, it's not very helpful, and we've got to deal with the reality of the situation. As it turns out, it's been my experience that pediatricians are not all that educated about radiation risk either. Radiologists and radiology professionals have got to proactively insert themselves in this void of knowledge and have to be seen as the people that give the information out. Questions come up all the time, and invariably what they're asking is, what is the risk to my body and what is the risk to my child? You've got to be prepared for those questions. I want to just point out a great resource here. This is from Frederick Fay et al., and it's basically a very, very good discussion about radiation dose and risk in pediatric nuclear medicine. A lot of the information that I have here is obtained from them. I would urge anybody working in the nuclear medicine field to grab this article and to utilize it and have it available inside their department, because it does give, I think, a lot of useful graphs, it gives a lot of useful tables, and it gives a lot of useful information to allow you to be sure you're on the cutting edge of making sure that your nuclear medicine department is Alara compliant and at the cutting edge of Alara. A couple of pointers. These are things that I've utilized. These are things that they also recommend to utilize, and it involves talking to patients. Obviously, the nuclear medicine procedure will involve the patient receiving small amounts of internal radiation. This scares the patient, and they need to know what that means. But essentially, I find that it's very helpful to say that internally this substance will emit radiation. It's very similar to the radiation that's emitted when an X-ray machine is basically aimed at the patient as opposed to having the radiation inside the patient. And the dose is very similar to other X-ray procedures. The exposure, as far as we know, leads to a very, very slight increase in the risk of contracting cancer sometime in the patient's life. And having examples of relative risk, which we're going to may be very helpful here. And really, I concentrate on just going through the risk-benefit discussions. That is that multiple doctors have looked at this, and we think that the information we're going to obtain clearly is going to help with making decisions that are going to be a positive impact on your health. And for that reason, we think that this very, very small risk is worth it to get that information. And that again generates a lot of discussion, and it's often very, very calming to the patient. And I think that they do like to know that their health care team is working as a team, and this allows them some insight into that. This comes from that paper by Fahey et al., and basically gives, it's not a chart that I had really ever seen before, but it's kind of an interesting, it's the lifetime risk of death from various things. And as you can see, unfortunately, in the United States of America, assault is something that we have to worry about a fair amount, but accidents while riding in cars are something we have to worry about. And much further down the risk are cancers from a PET scan in a 10-year-old, cancers from a bone scan in a 10-year-old, cancers from a PET scan in a 40-year-old, and then even less likely are things like accidents from falling off of a ladder or being hit by lightning. So it kind of puts this into perspective of what kind of risk we're talking about. Again, very, very small risk in the overall lifetime, but still something that it does have some tangible nature to it. We're going to move on from nuclear medicine now and start to touch fluoroscopy. Fluoroscopy is a procedure that we're all familiar with, dramatically declining due to endoscopy and CT, especially true in the adult population. We've seen our fluoro schedules truncate at virtually every hospital we service, but we still do fluoro, and fluoro remains a viable option for the pediatric population particularly, and we see it in VCUs and upper GIs and contrast enemas, all the things you're familiar with. But I want you to not forget that fluoro is also used sometimes out of the confines of radiology, including orthopedic procedures, central line placement, gastroenterology, and cardiology. And I want every radiologist and radiology department to be sensitive and proactive that all fluoro utilization in the hospital offers a chance to essentially evaluate for adherence to Alara standards, standards that actually are not paid attention to quite as much by the orthopedic population and even the gastroenterology population. We are the experts at this, and we can really add value to their practice, and I find conversations with them about this are very good at solidifying relationships, and I would like everyone to assume radiology to essentially be the fountain of knowledge for a very, very well-balanced and very, very proactive Alara culture inside of your hospital. It allows radiologists to really assume a nice clinical role if they have the knowledge and are proactive about their discussions. As it turns out, Ohio is actually a great state to discuss because Ohio is, in our experience, we deal with 6 other states, is very unique and very, very focused on Alara. And we're going to go through a couple of the things that are actually mandates of Ohio. But for one thing, and you are probably familiar with this, all individuals operating fluoroscopic equipment and individuals likely to receive an annual effective dose equivalent in excess of 1 millisievert must obtain a fluoroscopy course. As it turns out, some of the information of this lecture is indeed from that fluoroscopy course. It's an excellent 2-hour examination performed by physicists and basically gives you a good insight into some really effective things that you can do inside the fluoroscopic suite. As it turns out, even if you're a good fluoroscopist, if you get exposed to a fair amount of radiation in excess of 15 millisieverts over 1 calendar year, you actually have to go back and do a retraining course. So again, a lot of focus on making sure people are very focused on decreasing radiation exposure in a fluoroscopic environment. Additionally, they're very adamant in Ohio about only a licensed technologist or licensed practitioner within the scope of practice may perform adjusting the X-ray procedures, activating a switch that exposes a patient, or being sure that even pushing the fluoroscopic equipment can only be done by licensed practitioners. Even under a physician's orders, scrub nurses, etc., who don't have a license cannot operate in this regard fluoroscopic equipment. So the law and the mandate here is very specific in the state of Ohio. Just a couple of housekeeping and boring stuff related to fluoroscopy. Air kerma is a term that I think anybody who uses fluoroscopy is aware of. It's kinetic energy released in unit mass. It measures the initial amount of charge liberated by X-ray ionization into the air. The unit is gray or milligray, and a close relative that deals with this plus an area is dose area product. But both of these are designed to allow for some accurate or semi-accurate estimation of skin doses exposed to fluoroscopy. As it turns out, both are relatively inaccurate, but both still measure adequately and better than just fluoro time alone, the amount of radiation exposure. And I think you're going to be seeing a lot more attention to this particular detail. And these measurements, I am sure, after following the California initiative, are going to be part of the standard reporting requirements in the not-so-distant future. So I would keep an ear out for that. So what are all the hype about fluoroscopy, and are there really effects? There are two major health effects centered around fluoroscopy. There's deterministic effects and stochastic effects. And deterministic effects, and this comes from the fluoroscopic safety course by the Ohio Medical Physics Corporation. And basically, we know that if we expose the patient to a certain amount of radiation, the skin will start to essentially become red and glow. And that can get to the point where there's actually dermal necrosis and even hair loss if exposed to the scalp. Cataract involvement as well. And this gives you some idea of the dosage requirements and the time of onset that some of these may occur in. And these are some real pictures of some deterministic effects of radiation exposure to a patient who had a very prolonged coronary artery procedure. And you can see some erythema and some early necrosis that then progresses to delayed necrosis that required then skin grafting to help with. This is a CT scan that was performed on a patient, and you can see that there was an intense exposure to a very narrow band that produced then the effect of causing hopefully temporary hair loss in this young female. The stochastic effects are also very important and probably ones you may get more or have had more experience or more discussions about, and those essentially relate to cancer, leukemia, and hereditary effects based on radiation exposure. The risk seems to increase with increasing doses. Children, again, more affected. Women, more affected, probably because of breast sensitivity. There is some known genetic predisposition. The most elevated of these syndromes is Gorlin syndrome, where there's an increased incidence of basal cell carcinoma in people that have that genetic predisposition around radiation sensitivity. And even lifestyle choices, we know obesity, smoking, and alcohol seem to increase the inability for a body to tolerate radiation, and again, a good idea to eliminate obesity, smoking, and moderate alcohol exposure. We do know that the Ohio Department of Health puts limits on monitored personnel. I hope we all use our monitoring devices because they are there for your protection, and this is the Ohio limitations that you probably are all familiar with. It's interesting, you probably know there's no lifetime limit, there's no patient dose limit, and there is a declared pregnancy limit, but one must declare the pregnancy in order to be under the auspices of that limit. And we also know that by law, the fluoro unit can't exceed 88 milligray per minute in normal mode and 176 in the boost mode, and more will be said about the boost mode, but this should be utilized only when absolutely necessary. Typical fluoro units are actually far below these numbers. This just gives you an idea of some of the common exams we use and how much radiation dose we're talking about. And you can see that in the common examinations, we're far below anything that is going to be problematic if utilized appropriately. We do get into some significant radiation exposure when we're doing stenting and coronary angiography, and those deterministic pictures I showed you earlier are examples of that. So again, these are places where anything we can do at all to decrease the dose of radiation to the room as well as the patient, we really ought to be doing to be sure that we don't get into some of these deterministic effects. So I'm going to just go through a few things, and these are all things that everyone's probably familiar with. Good to have them all in one place, but we'll go through 4 factors that I think are very important when evaluating the fluoroscopic suite. Time. It is absolutely essential to be efficient with pedal time. If you're not watching the monitor, you ought not to be fluoroing. I can tell you that when I started as a radiologist, this was an enormous problem for me because I would get ingrained in what I was doing and find myself with my foot on the pedal and exposing the patient whenever I was not looking at the monitor. And it really requires some significant time. So for those new radiologists that float through the department, this is something to watch out for. One of the things that I instituted, and this really is very, very helpful, is that I have the technologists actually help me monitor. And they are instructed that if they see poor utilization of pedal time with respect to the fluoro unit, it is perfectly appropriate for them as a fellow colleague helping out the patient to give me a reminder or one of my radiologists a reminder that, hey, you know, watch that pedal. And we laugh about it, but it's a very, very good second check on me and a second check on a radiologist. When using pulse fluoro, remember, if motion isn't an issue, you can save an enormous amount of radiation to the patient in the room by just decreasing the pulse rate. This obviously is important. If there is motion involved, the pulse rate can't be decreased, but often you can decrease the pulse rate and thus decrease the radiation, and it's important, obviously, to use pulse fluoro if at all possible. One of the things that I find that people don't use as much as they should is image hold, and to use the fluoro save procedure that is on almost all machines these days. It clearly prevents you from having to take a picture, which really increases the dose of radiation. And obviously, if you're using digital runs, they should be carefully monitored, carefully planned. Digital runs clearly increase the amount of radiation exposure significantly. Distance. This has all been drummed into our heads, the inverse square law. Doubling the distance can quarter the dose. This should be kept very much primarily in the mind of everybody in the room. Standing one step back from the patient or from the radiation source is very important and decreases the radiation dose significantly. If the patient can be managed away from the edge of the table that's closest to the primary fluoroscopist, this will decrease scatter. When doing lateral fluoro, it's really important that people congregate on the side that the beam is aimed towards and not on the side where the beam is generated. You get significantly increased radiation dose standing next to the generator when utilizing lateral fluoro. That's a very important point and something everyone should keep in mind. One of the points that the fluoroscopic safety course really drummed home is the use of spacer cones on C-arms. It is inappropriate to take off spacer cones. These are designed to be sure that there is a minimum distance between where the x-rays are generated and where a patient could possibly be. There are some clinical situations where they have to be removed, but that should be absolutely the exception, and they should always be replaced. Spacer cones absolutely help protect patients, and it is law that they be utilized properly. Remember, keep the detector close to the patient and keep the patient far from the generator, and that keeps you out of trouble for sure. Shielding. Shielding is often over 99% effective. No one likes to wear those heavy shields. Everyone would like to get rid of them. But in the fluoroscopic room, you must have, in the state of Ohio, an apron or a shield. This is not the place to be styling. No plunging necklines, no miniskirt shields. The sternum has a significant amount of bone marrow edema that is susceptible to radiation, and the femur, the long shaft of the femur, is also very susceptible to radiation and contains a good deal of marrow that you do not want to have exposed to excessive radiation. Use drapes when possible on the fluoro towers. The exception that I use is the myelogram. I don't use the drapes, but for the most part, I use the drapes for every single procedure, including the pediatric procedures. Thyroid shield is optional. But it is useful. Obviously, thyroid cancer is the concern, although it is a very low risk. If you're really around fluoro a lot, it's one additional added protection I think that's probably useful to have, as well as glasses, which also should be used for heavy fluoro users. Clearly, we want to prevent cataracts at all costs. As it turns out, you must use gloves if you're putting your hand in the beam. I have a better suggestion: don't put your hand into beam. Again, in the pediatric world, it's sometimes necessary, but it's really a bad habit to get into, and it does expose some of your marrow to unneeded and unnecessary radiation. Side drapes are also very helpful, but I know some people find quite bothersome. Some general recommendations: keep the image intensifier close to the patient. This is something that I monitor a lot with the people that I work with, and obviously keep the patient away from the X-ray generator if you have control over that. Use pulse fluoro, but use the lowest frame rate and the largest field of view, avoiding magnification if at all possible. Aggressively collimate. Control of your collimation and making sure the collimators work appropriately is really a stickler of mine. I find so many departments that I interface with where for whatever reason people don't pay attention to the utilization and the maintenance of the collimation system. It is a truly sad fact, because it really is a big component of having an Alara compliant department. Remove the grid if the patient is thin or pediatric. There's no need for the grid. It just exposes them to more radiation. And we talked about the boost mode. Again, very sparing use if at all. This can increase exposure 10x. Get used to reporting and understanding some of the values that we utilize for radiation exposure, like air karma. These are clearly better than fluoro times when monitoring radiation. I would add filtration when possible, and again, we discussed making sparing use of digital spot images. Utilizing the fluorosave procedure is probably one of the most underutilized things that I find when watching people do fluoroscopy, and it's certainly something that we can utilize to decrease radiation exposure because of digital spot imaging. Back to the Ohio Police again. All fluoro exams, pregnant patient exams, interventional and cardiac procedures must record the following. You have to include a measure of the cumulative air karma or dose area product, and if this is not available on the older units, then you must record the fluoro time, and with the fluoro time you must include the number of pictures taken and the mode of fluoro operation. The patient name must be logged, the date of the procedure must be logged, the type of exam must be logged, and the operator's name must be logged. And you cannot have anybody operating that fluoro unit who has not taken their 2 hours of the fluoroscopic safety course, which I highly recommend, very professionally done. I want to put a pitch out to the Ohio Medical Physics, which has just done a great job in putting together this education program. And again, it's I think a good measure of where Alara has come to here. We also have a national look at this, and the fluoroscopic timer must be a 5-minute cumulative timer with an audible tone. I've watched some places turn off that audible tone. It's very important for me to know where I'm at in my fluoro exposure, and the audible tone is an absolute necessity. The exposure switch must be a dead man type in which pressure must be applied to cause an exposure. The SID has to be no less than 12 inches for mobile units, 15 inches for stationary fluoroscopy, and generators and timers must be checked and maintained, and there must be a log kept, and I think all of you know that. The patient must be visible to the technologist at all times. This is a mandate. And the lead curtains must be at least 0.25 millimeters of lead equivalency, and all persons in the radiographic room, whether lead or lead equivalents, must wear a 0.5 millimeter lead equivalent apron. Intermittent beam on and off is recommended, as well as use of, again, image hold techniques. Here's that word again, communicate. Be sure you've served as a consultant prior to the examination. If there's any question of the examination before you expose the patient to radiation, a conversation or a discussion is absolutely essential, and I find no kickback on this at all. I will tell you, when I'm calling a doctor, if I let him know that I'm concerned about his patient, then there's usually a very good conversation. Have non-radiation methodologies been explored mentally to answer the question? This is certainly a question that I ask often. Is the correct exam being ordered for the correct indication? And if you have a question, again, this involves a communication. But in the end, it's just important for you to be the patient protector. Your crew and the radiology department in general should be an advocate for the patient and an advocate for the appropriate utilization of radiation in your department, and that is something that just must be at the forefront of everybody in the radiology world at this point. So we've covered then nuclear medicine, we've done a review of CT, we've taken a look at fluoroscopy in the scope of Alara. We're going to finish up this evaluation and discussion with looking at what's gone on in the world of DR and CR. And again, the pediatric community and Image Gently and now Image Wisely are at the forefront of this. They have produced a relatively extensive education, awareness, and advocacy campaign to look at how it is we're utilizing plain film usage in this population and others. And they are dedicated to monitoring and providing advice and innovation to ensure that Alara guidelines are followed in the care of children and, for our purposes, in the care of all patients who we are exposed to. This is supported by the Alliance for Radiation Safety in Pediatric Imaging, which is composed of greater than 70 healthcare organizations, agencies, and more than 800,000 radiologists. The ultimate goal is to change the way we practice and to raise the awareness. And the spirit of this lecture is exactly that. We really want to be sure that we are very involved in the educational process with radiation awareness. The success of Image Gently helps spawn Image Wisely, which is directed toward the adult population. And I would really urge that everybody who is involved with radiology try to go to their websites and utilize what appears to be just an ever-growing collection of just superb resources for the purposes of monitoring and patient education surrounding the concept of Alara. We talked about background radiation and BERT. I think this gives you a good idea. Remember that a single chest x-ray does not produce that much radiation. But when you look at how many chest x-rays and how many radiology exams are produced in this country, clearly in most of our hospitals, well over 50% are plain films. So you can see that it's, although in the individual case, not a lot of radiation, in the conglomerate case, it ends up being a lot of radiation. The natural background radiation is 3 millisieverts per year. A chest x-ray much lower than that, 0.01. In fact, you can accurately say that you get more radiation dose by being a cross-country airline passenger than you do a single chest x-ray, and you'd be quite accurate. But when you start to get into the head CT and abdominal CT, chest CT range, you really are getting as much radiation as you get in a year from background radiation. And this is the purpose of BERT comparisons. It gives you an idea of how much in a day of exposure or in exposure days you would get for a particular radiology procedure. Background being 1 day, a chest radiograph also produces about 1 day of background radiation exposure or thereabouts. Head CT 8 months, abdominal CT 20 months, and obviously one of the effects of MR and ultrasound is that their background radiation exposure is zero, not a zilch, which means that if we can do the same thing with MR or ultrasound and get the appropriate answer, then we can do that without radiation exposure, and that's something that I think that all of us always need to keep in mind. Another way of looking at this is deaths per million. If you're 55, which I'm rapidly approaching, 10,000 deaths per million occur just because you're an old guy like me. Smoke a pack a day, and it's 3,500 deaths per million for smokers for a pack a day history. Rock climb for 2 hours, 500 deaths per year. A chest x-ray, 1 death per year. So much, much, much lower radiation risk, but still the risk is not zero, and in the fact that it's not zero is what patients really concentrate on. I find this particular way to look at risk, it's a very useful endeavor. It's something to keep in your back pocket. I mean, heck, if you're a farmer, you have a 10 times the risk of deaths per million than you do from a chest x-ray. So, you know, we see a lot of farmers who do quite well. But again, a very good chart to kind of have in the back of your pocket. I actually have a chart like this that I keep on a laminated sheet when I practice, and it gives me the opportunity to really, I think, lower people's anxiety significantly. At the same time, be very honest about the fact that there still is some measure of risk with respect to radiation. So does medical radiation cause cancer? The truth is, at these levels, it's very difficult to say yes. But above all else, I think what we're really charged with is we're charged with doing no harm to our patients and being the steward of doing no harm. We know there's potential. We need to step up to that potential. So what can we do just in case? Can we save one child or extend one life? Probably worthwhile, particularly since some of these actions are really quite easy to do. So these are some suggestions. We need to discuss measuring parts and thicknesses, only include the necessary anatomy, select appropriate techniques, no grids for parts less than 10 to 12 centimeters in thickness, immobilize effectively and aim the beam effectively at the patient so that the beam is utilized effectively, use collimation, not cropping, to decrease patient exposure and to get the appropriate anatomy in the field of view. And automatic exposure control does lower the dose, but probably not such an option for small children. So let's just concentrate on optimizing. Obviously, the picture to the right is a pair of calipers. It's funny, these are utilized an awful lot before, they're not so much, now being utilized a lot more. Measure the part thickness accurately, and this allows for some standardization. It is very important inside of a department to design, maintain, discuss, and use a technique chart for consistency. I like to think of Alara as being a team sport. I think it is a team sport. I would really urge that everyone use the huddle technique in the morning. And I do think that anything found on the technique chart or concerns about the technique chart, it's a very appropriate discussion point for morning huddles. It also allows everyone to re-engage every morning and every shift to be sure that everyone is participating in the Alara team sport. It's important to update your technique chart to provide accurate exposures as your equipment ages and as changes are made. So again, very important not to get into sort of the mode of, well, this is what worked 15 years ago. It's important to update that chart. It's important to check your anatomic programming for accuracy, and it's important to use automatic exposure control on larger patients. This allows for consistent images and allows for a lower dose producing those consistent images. Important to utilize grids appropriately in the radiology suite. As everyone knows, grids can improve contrast significantly. Essentially, for those who don't, it allows the primary X-rays to pass through unheated and efficiently, and allows scattered X-rays to be absorbed because they have to pass through a lead column, and allows those things that are not going in the right path to essentially be absorbed. It cleans up the primary beam and prevents unnecessary exposure to the patient, and importantly, it prevents unnecessary exposure to those people that are in the room as well. And this is just 3 different types of lead strip grids. Grids these days come in all size, shapes, and appearances. And again, for large patients, imperative to use for increasing the quality. But we always have to keep in mind that when we utilize a grid, it does add the patient dose. More oomph has to be behind getting more X-rays through the grid to allow for the X-ray, and that does translate into an increase in patient dose. Thus, it's important that we use the grid only on parts where greater thickness will produce scatter. Use the grid for body parts over 10 to 12 centimeters in thickness. And I put this in red and I put it in capital letters. Very few instances where the grid should be used for younger or smaller children. Do not just use the age of the child. And I will tell you there's no time that this is more important than now, because essentially, given the fact that we do have a lot of children that are obese, it's important to measure and adapt our utilization of grids to the population weight trained and the individual patient. It's impossible to do that just basing it completely on the utilization of age. How else can we optimize digital? Well, first of all, digital does not equal film screen. We cannot use the same thing. We cannot use the same techniques. And so you'd say, well, why in God's name do you have fertility idol and sandbag on the same page? If everybody remembers that the Indiana Jones movie is basically one of the very first ones, he's basically holding a sandbag and he's putting some sand kernels in so he can sort of estimate how much sand might be utilized to take the place of the fertility idol that he is planning on stealing. Well, he didn't get it very right. In the film screen world, there's a direct relationship between exposure and image. More exposure, darker image. In the digital world, that is not true. You can't feel the idol and feel the sand and say they're the same, because the computer processes and adjusts the image for an acceptable grayscale regardless of exposure. And this is the problem, and this is called the uncoupling effect. In the old days, film screen, basically, too high a dose, you get a black film. Underexposed, you got a light film. Very simple world we lived in, and we were very used to that. You cannot apply the same because of the uncoupling effect, because in the digital world, you can basically get the exact same film even if you've under or overexposed the image. Again, the computer masks the dosage error. You can feel safe that the sand on the statue disappears and the ball is rolling down at you, or at least it should, because you've overexposed the patient inappropriately. And obviously, if you're doing 25 or 30 X-rays a day, and you don't, keep in mind this whole uncoupling effect, you can really get yourself into trouble, and more importantly, expose your patient to radiation that they simply don't need to get the information that the physician desires. One of the things that's essentially an hour-long lecture that the Image Gently campaign has put together is exposure indicators. I'm not going to go into great detail here, but we are going to get into the point where we're going to have a lot more control and more feedback about the exposures we use in the digital world. This is designed to be a primary tool to ensure that accurate exposure factors are being used when using digital equipment. It provides essentially a measure of the efficiency and sensitivity of the digital receptor to X-rays. And then this information is provided as feedback. If you think about it in terms of just fly paper, the flies are the X-rays coming across, and this gives us an idea of how exactly sticky the fly paper is in actually accumulating the data from the X-rays. And this information up to now has really not been very available to us, and it would be very useful, as you can see. There are some proprietary exposure indicators. So if you go to Fuji and Agfa and Kodak and ask them, they are using some measures, but they're not harmonized, and importantly, they're not comparable, and this is about to change. It's very important to understand these issues at buying new equipment. One of the reasons why my group always tries to insist on being involved with equipment purchases is that we want to be able to make sure we have a mind's eye on Alara and have a mind's eye on utilizing whatever new features are coming to bear with respect to Alara and with respect to radiation exposure. And we strongly urge the radiology community to be very involved in their equipment purchases, again, with Alara firmly in mind's eye. There is then a new exposure index that's coming out. There's been a creation of an international standard to eliminate confusion. This will be applied to all future digital imaging. It will essentially allow us to have some idea of how sticky the fly paper is, and we hope will allow for a patient-friendly and more cooperative environment in the whole arena of DR and CR imaging. Obviously, we want to be very careful about optimizing dose, and we want to be able to participate in the ACR's dose registry, and if you're not participating, I urge you to be involved in that. It's still an inexact science, but we want to be involved in making sure that we are decreasing the dose to the lowest possible level for the patient. Obviously, DAP measurements are becoming more prevalent in this arena. Utilizing them and probably reporting on them is going to be necessary at some point in time. And one of the things that I really urge my staff to do is to be very proactive and eliminate things before they're done. And these are the most common reasons why there are redos. Having these in your mind's eye and kind of going through them in your mind before doing the patient really can decrease the number of times you have to redo film. And these are things everyone knows about: artifacts, mispositioning, over-collimation, patient motion, double exposure, poor inspiration, overexposure, underexposure, wrong markers, wrong exam, wrong patients. Some of these are very serious issues, but having these things obviously as part of your workflow, as an active part of your workflow, can decrease the amount of radiation exposure significantly. We also want to be sure that we're not utilizing imaging cropping in place of collimation. We want to make sure that there aren't technologists who are essentially using overexposure because it's easier and I don't have to repeat the exam. This is a very common thing that I've encountered. And then there's just some people that are so focused on the histogram that they're not actually looking at the film or looking at the exposure rate. So again, I think these are areas we can be very proactive and essentially eliminate unnecessary radiation exposure. There is a new approach to this that the Image Gently campaign is out with. I'm going to give you a little bit of information. Again, there's an entire lecture that's devoted to this, but this will give you some of the basics, no pun intended. But this is the Back to Basics campaign centered around the DR and CR utilization in pediatric population, and certainly applies to adults as well. This comes from the Alliance for Radiation Safety and the Image Gently campaign. So back to basics. If we look at basics, beam, artifacts, shielding, immobilization, collimation, and structures. For the B, basically is the anatomy in the center of the image. Make sure that we have absolute awareness of where the central ray is going, what the tube angulation is, the device alignment. As my little friend who keeps following me around says, hey, you know, Mom keeps telling me aim carefully before you sort of press the button. And I would recommend that you sort of aim carefully before you press the button. Artifacts. Prior to doing the image, does anything obstruct that requires a repeat? How many lighters have I seen in pockets, earrings in appropriate places? Prior to doing the examination, make sure the artifacts aren't there. It's well worth the time, and it's well worth the radiation savings. The goal here is to be proactive prior to firing the flies into the flyer paper, and this eliminates this as an issue pre-radiation and proactively. Shielding. Again, something I find that people don't pay a lot of attention to, but the rule of thumb is that a shielded gonad is a happy gonad, no matter if you're a boy or a girl. So there's an awful lot of shielding options available. Please utilize them. it is important to protect. Immobilization. Experience is invaluable in assessing immobilization, but I will tell you, being upfront with the patient, trying to develop a little relationship with the patient, whether it's an adult or a child, will often allow them to maintain immobility for the time necessary to take the x-ray without having to use support sandbags and pigos. So it's important to be going out, talking to the patient, utilize that 1-2 minutes to do two things. You can assess the patient and perhaps the parent's interaction with the patient. That'll give you a good idea of what success you're going to have, and it develops a little bit of trust so that you can actually decrease the number of times that you have to actually put a patient in a pigo or swaddle them or distract them. So it's a very good idea to try to establish that relationship. Who would think that that's an Alara concern, but it really is an Alara concern. That is the development of that relationship. Collimation. Is it appropriate or no? Certainly, collimating is important. Reliance on electronic cropping as an afterthought is not appropriate. Think, collimate, protect. There are serious legal ramifications to this. If you have exposed a patient to an area on the x-ray and you do not present that exposure to the radiologist and you crop it down to make it look good, that radiologist, as it turns out, is still liable for the evaluation of the area that you've excluded. That's not true if you collimate. So it's very, very important both from a patient protection standpoint and a legal standpoint to be sure that if the patient is exposed, that portion that's exposed is evaluated in the radiology evaluation. And the legal profession is quite firm on that particular point. And as structures, I would suggest basically making sure that you are imaging the anatomy properly and make sure that the anatomy you're imaging is answering the question that is asked on the sheet. Again, we're getting lots more information from physicians now. Be sure that we utilize that information appropriately. Be sure that that information is utilized to help make sure that we are an Alara compliant department. So that's going to end our discussion. I again would end as I started with. We are very heavy into another lecture called Evaluating for Safe Departments, and this includes obviously Alara, but there's a lot of other areas, including GFR analysis, creatinine analysis, and looking at exactly how it is that we can be as safe as possible inside the radiology domain. And we think there's a lot of value in looking at this and really evaluating for safety checklists. And as the little guy says, if you don't want to invite me back, invite him back because he thinks I talk too much. And so I'll give one last pitch to the Image Gently campaign, the Image Wisely campaign. They are definitely areas where we can get some information. Other websites of interest that I had put in the other lecture, the Health Physics Society, the Ohio Physics Society to help me with this lecture on the fluoroscopic arm of this, but also the ACR and the RSNA are really gearing up their sites to be sure that they serve as useful repositories of information so that when you have a question about Alara, you have a question about radiation utilization, that you can find a very good resource for it. And particularly the RPOP is a very good place I find because it does allow us to deal with safety and dosage issues in very plain language, which I think is sometimes helpful to refer patients to as well. So basically, I'm going to end here. This is a trumpet player. I'm not necessarily a blowhard, although I think this guy was a blowhard. This is a look at his larynx, and over time, he obviously distended that by hitting those high C notes pretty hard. I'll remind you that digital should not be faceless in your department or my department or anywhere. In fact, if there's ever been a time where radiology should be faceless or faceful, where radiology should be a very visible part of the hospital community, it is now, knowing what we know. And I would urge that this be part of your philosophy as well. And as I sit here in rainy Pittsburgh, I clearly wish I was there, but I'm not. And I find my voice and my attention span fading, so I'm sure yours is as well. So we're going to try to fade out here, and I ask everyone to not only drive carefully, but I would hope that you would image carefully, whether you're in Las Vegas or whether you're in Ohio. I think that's important. So that ends Alara 2.0. I hope that we at least got to answer some questions that maybe you had about what's going on, and hopefully, more importantly, generate some discussion inside your department about radiology issues.